and the director of the Global Observatory of Long-Term Care, and I'm delighted to welcome you all to the first webinar of the Global Perinatal Mental Health Group. Just so you know a bit about the observatory, I'm going to share a couple of slides so you have an idea, and also how to interact with us. Right, so the Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care systems. It's part of a wider organization called the International Long-Term Care Policy Network, based at the London School of Economics. And our aim is to identify shared challenges and showcase how different countries and localities are addressing them, sharing research evidence and facilitating collaborations. It's open to people working in the sector, policymakers, industry, but most of us are actually academics. And I'd like to say, we call ourselves Global Observatory of Long-Term Care, but we do use a very broad definition of long-term care, which basically includes anything that we think has long-term consequences and impacts in people's lives. We adopt very much a life course perspective, which is why we're particularly pleased to have this interest group joining the observatory. Just so you know how it works, basically the key is to become a member. For that, you need to fill in a profile. It's free. All you do is tell us a bit about your interests, expertise, your key publications, and you can then get involved with any of the interest groups. You can also send us blogs and announcements of new publications or events that you'd like people to know about. And to join, we've got the QR code. It's a good one. It's genuine. That takes you to how to become a member. Some of you are already. Some of you hopefully will join us after today. And just so you know, our next webinars, they're a bit more on the more traditional long-term care topics, the next few ones. We've got one on accountability mechanisms in nursing homes on the 25th of February, one on quality in long-term care on the 3rd of March, and one on, again, focusing on care homes, this one on ownership, asymmetric information, and quality of care, looking very much at evidence from nursing homes during the COVID pandemic. So that's it from me. Just wishing you, giving you a very warm welcome, and I'm very delighted to hand over to Annette Bauer, who will tell you about this interest group.
Yes, I'm just going to talk a little bit about why we created this kind of like global perinatal mental health interest group. I hope you can see my slides now.
Yes, thank you.
Great, amazing. I hope I'll be quick and then hand over to our special guest, Jeannette Milgrom, who's giving the first kind of like presentation. The purpose or the vision of the group is to kind of like bridge the data to delivery gap in perinatal mental health to inform the scaling of evidence-based treatment and support globally. I think just for those who are kind of like still new to perinatal mental health, and apologies to those who are not, just to kind of like give you some key figures on why perinatal mental health is becoming such a priority, including what we feel like should be kind of like recognized priority in the kind of like long-term care field. So it's worldwide, 140 million babies are born every year. And globally, up to 1 in 3 women, at least in resource-poor settings, develop some kind of mental health problems during pregnancy and following childbirth. So perinatal mental health is basically defined as that period during pregnancy and the year or 2 years after birth. And it therefore really substantially contributes to the global burden of disease. There's now a lot of data out there to confirm that. And that's because of the impact, not just on the mothers, but on the children, which is often not just during the perinatal period, but ongoing. And we calculated, as part of teams in different countries, the kind of cost of untreated perinatal mental illness, and found that those range from, they're always in the kind of like billion range from, depending on the size of the country and the prevalence, 3 to 17 billion per birth cohort. And we also know that perinatal depression is responsible for a lot of child stunting cases, for example. So a study found that 3.2 million cases of child stunting that are attributable to maternal depression. And suicide is the leading cause of maternal mortality, and it's accountable to up to 40% of death. And there is actually quite good evidence. I know it's not perfect. There's still many evidence gaps as well, but there is evidence-informed guidance from the WHO, but also from many countries on what actually women should be getting during that time. but obviously there's a huge treatment gap. And so that really brings me to the next slide. So that's, I think, in some ways, like why this group exists. So there is this kind of like huge gap. So it's estimated that only 90% of women with perinatal mental health problems are actually, it's 90% are not being identified, so not being offered any form of treatment. And we feel that a group like this might have kind of like offer some learning opportunities. So obviously there are many learning opportunities, but we felt that there's one around kind of like research sustainability. It's quite specific in some ways. So I'm definitely curious. These are just kind of like proposed kind of like ways of how we could design the group. But one way would be really to kind of look at, okay, there's already amazing kind of like global perinatal mental health research projects happening. And they increasingly have a remit to kind of like think about building capacity, but also to kind of like make sure that there's something sustainable and scalable after the research actually ends. And there are opportunities to kind of like really share learning about this because it's happening. But I don't think we actually talk a lot about it, at least not specifically to perinatal mental health. And overall, I think we're not yet as good in kind of like sharing knowledge about how to build that kind of capacity. And the other kind of like perspective is the kind of like cross-sectional angle. So perinatal mental health is increasingly growing, but there is kind of like limited exchange kind of like with other fields who actually that could help us kind of like that have similar issues around, for example, integration, digital technologies, task shifting, community capacity building, and so on and so forth. And so that's why we thought like this kind of like network that Adelina built up successfully, obviously not on her own, but with many colleagues internationally, provides such a kind of like useful kind of like infrastructure. They achieved kind of like major changes during the COVID pandemic. Like there's a really, there's a great buy-in into that network. So we feel like this is like a great opportunity. But all of this is for discussion. So it's right now more an idea than an actual group. But we have some people involved. So we have Jeannette, which is amazing, and Yafet and myself kind of like helping out with organizing the group right now. And then we have a wide range of steering group members. I'm hoping that some of them will join or listen to the recording if they couldn't join today, who are signed up to that group and who help us kind of like making the group happening. But obviously this group, whoever's attending, is also becoming part of the group, as I think Adelina was trying to say. So you just have to literally sign up and then you're automatically becoming part of it, and you can become as involved as you want to. If you have ideas of how we can use the group, this is basically completely up to you. Contact us, get in touch. Because obviously we only have this hour today, so there might be limited room for discussion, but we would really appreciate ideas if you think there could be an opportunity for you to kind of make something out of that group. So right now, what is the group doing? So we have different topics that we think are really relevant to kind of like scaling around digital technologies, task shifting, cultural adaptation, community-driven solutions, system strengthening approaches. And, whoever knows me knows that I'm producing economic evidence. Obviously, there's a really big role, I think, to discuss economic evidence and how it can inform scaling. And then there are various kind of like activities that we could get involved. So at the moment, we literally only have the kind of like seminar series, but we have other opportunities, like we can produce resources, case study summaries, training and development resources, social media contents. We can offer practical tools, blogs, website materials, and videos. Like all of that are possibilities. I should say, right now we don't have any funding for the group. So it's all going to be based on kind of like things that are already happening maybe elsewhere, and that have kind of like relevance to this group, I suppose. But we can think about also like exploring funding going forward. And anyone can join, obviously, so it's very kind of like inclusive. And I think it's really about kind of like, like really supporting also like those who are new to the field, either because they have been working somewhere else or they just kind of like started their career, early career researchers. And anyone kind of like really interested in discussing, in particular, capacity building for perinatal mental health research and practice, but also people with expertise or interest in understanding how to develop sustainable financial models, implementation strategies, and delivery methods. And these are just some of the upcoming webinars. So obviously, as Jeannette presented today on a very exciting topic, which I think is so relevant to, this kind of like scaling discussion. And I'm going to hand over in a second, but we have some kind of like upcoming seminars planned, including from Roman Stewart about the CHIME intervention, which is a culturally embedded intervention. We just came back from the Gambia, where this has been already feasibility trialed, and there's a larger trial now happening, which has been absolutely amazing to see how much local buy-in there is in that kind of intervention. And it really kind of looks like something, yes, we can make it scalable somehow, not easily, but maybe we can. And Rob Stewart and Genesis Corvey are presenting on all the efforts they have been doing in Malawi to kind of like improve perinatal mental health over many decades, actually. And then Linus Movi and Vivette Glover have a perspective from Zimbabwe on how to kind of deliver holistic perinatal mental health care in underserved populations. So these are just examples of webinars, but please, if you have ideas, if you want to present, just get in touch with us. We only have a limited number of presentations per year, but we are trying to kind of like fit that in. And yeah, it would be amazing to kind of hear from you. And I'm going to hand over to Jeannette.
Thank you very much. It's wonderful to be here today. And I do encourage, I know it's always a strange thing with, online talks. Yes, do. Thank you, Megan. Do take courage in your hand and turn your videos on. It's nice to talk to an audience, but if you don't want to, that's fine too. I'm going to talk for half an hour and try to allow some questions. I think I saw Rhonda lurking there in the background too, and I see familiar faces. It's very nice. And please don't be shy. You know, it's great to all be here with a common interest. So I'll start by saying thank you, Annette, Adelina, and Naz for organising the GOLTC series, and it's a good segue to my talk because, as you know, Annette, it had its seeds in some of the activities of the STePPS CRE, where we were initially talking about developing webinars and what an important thing it was to do professional development and also to have these international webinars. So, you know, we hope the ongoing partnership with STePPS will happen. So I'm going to, without further ado, I'm going to start my talk. I'm going to be talking, as you know, about digital technologies. And so I'll introduce, as you can see, the STePPS CRE and also MumMoodBooster in Australia. And some of you will know, because I've seen a few people who put their cameras on, some of you will know about it and it may be new to others. So bear with me if some of it you already know. And that beautiful baby is the statue of our institute. So Annette encouraged me to say a little bit about myself and how it all began. And it really, something like what we're doing now is something that didn't happen overnight. You know, and it's interesting to look back and look at the seeds of how you build something such as what we're doing now, which is STePPS CRE and MumMoodBooster. So that's the building I was in a very long time ago. I actually, it's in a general hospital, and initially it was an empty building, and I squatted in it, and that's how I ended up getting a home for the Parent Infant Research Institute. But I'll tell you a little bit about my story. So at the time when a lot of things started in perinatal, I was director of psychology in a general hospital. Over time, I became a professor director, and part of it, of my interest was always babies. I loved my own, and I did my PhD in this area, and it was really something that I was fascinated by. And initially, I was a child psychologist. But what I saw was that the infant was missing in practice. And I was very lucky. The hospital gave me a fellowship. I went off and I trained with a wonderful late Sarge Lebovici in France. And France really was very advanced in infant mental health in a way that, other countries only slowly took the mantle. And infant mental health is still a niche area. So I came back to Australia and I established a clinic, and it was just amazing to see the changes you could make in parent-infant interactions with infants in difficulty. So then I didn't want to stop there, and I established the Parent Infant Research Institute. a not-for-profit organisation based in the hospital with a team of, which, you know, these things are not one person ever, you know, passionate about making a difference. And we've really done some amazing work over time. And I was very lucky to be awarded a Medal of the Order of Australia, recognised by the government in 2018. So our mission is research into understanding and preventing the consequences of perinatal depression, and particularly alleviating. So a lot of our efforts went into treatment. And, you know, as Annette has nicely introduced, you know, we know how many women become profoundly depressed each year, and we know the impact not only on the mother, but men and non-birthing partners. And critically, you know, what still isn't really upfront, but is shown in your economic figures, Annette, is that it disrupts the first 1,000 days of life too often. And creating, without, you know, in a certain proportion of women, an enduring problem. And Annette, these are your figures that I got from one of your papers. So here we are. There's lots of references there, but you can see Annette, the famous economist, is 4. So we're a research institute, and we try to sort of deal on facts. But what we really focused on was that only 1 out of every 10 women seemed to be adequately treated. The studies, the best studies, are quite old. They're actually in 2005, because you need huge studies to follow it up. But at the recent Spain Marseille conference, there were some large studies that showed some rather similar findings. So over 21 years, the first 21 years, what did we do? We developed treatments. And we started off with, in 1999, with face-to-face treatment. And this treatment, getting ahead of postnatal depression, has been so successful and trialled in so many randomized trials that Wiley, who have published the manual, are just doing a 2025 edition. So all these different treatments, first of all face-to-face. And the last column here is where we've moved to, which is the digital. So I'll show you how we moved from developing postnatal treatments, antenatal preparation like towards parenthood, mother-infant programs, to where we are now. Why did we develop e-mental health interventions? Well, you saw the figures that I'm quoting that Annette, even with the best health system, we cannot reach all women necessarily for practical reasons. And in addition, we would like to provide choice for women about the medium and the type of treatment that they would like. We want to reduce consequences, obviously increase uptake, and reduce barriers to treatment uptake. So over 10 years of research, we began working with a wonderful American group, Brian Danaher and his team, and with a wonderful programmer, Tuan Trang. And we started off with NIH feasibility money, then Australian, very good. We've done 3 randomized trials. And what we tried to do is mimic what we'd had done in our face-to-face therapy. So it's not psychoeducation. It really does try to take the mum through the steps that would occur in a face-to-face treatment. I'll just give you a taste of it if I can. So here we are, and you can, mums can
You've
register.
arrived at session 1, the first of the 6-session MumMoodBooster program. We know that many mothers with new babies can have difficulty finding the time to use the web program, as well as making changes to your everyday routine. It can be hard to put yourself first, but by doing so, you will be in the best position to manage all the demands of motherhood. One last point before you get started. Please take your time, about a week, to work through each of the 6 sessions. There really isn't any benefit in going any further.
So you can see that what we do is we use everything we can. We have a host, like, who introduces it. We have 6 sessions, which are CBT, interpersonal psychotherapy, mother-infant. It's a wonderful conglomeration. And we have some wonderful evidence over 10 years. And so that's just to show you there really is some substance behind this. And in summary, we did an efficacy trial. And what's different about our treatment is that the inclusion criteria, women, it includes women and largely targeted for women with diagnosed depressive disorders. So we found a 2-arm RCT great adherence, and probably the best study that we've done for this is a 3-arm RCT where we compared it to a well-evaluated face-to-face treatment. And you can see green is MumMoodBooster, how well it is doing. And that was a surprise to ourselves that it did so well. It was at least as good as face-to-face CBT in producing remission from a depressive episode. And this shows you that the symptom reduction was faster. So here we were, we did 10 years of work, and we thought, what do we do now? And we were incredibly lucky to see, I feel very privileged to have seen our work translated into practice. So the Australian government picked it up, and we now deliver MumMoodBooster to all Australian women free of charge, which is really that translation of research to practice is something that is, and there's a paper about to be published talking about our first 7 years and of what we've done in that time. And this is what it looks like, the homepage or the home website where MumMoodBooster lives. So MumMoodBooster is there. There's a pregnancy mum-to-be mood booster. And then we have other resources, universal supportive resources, parenting resources from Jane Fisher, David Kavanagh's baby steps, so that we think about a step care model, but the online treatments, the MumMoodBooster program is what the government has focused on. And over 7 years, 244,000 women have accessed MumSpace, and we get about 2,000 women a year treated who register and go to the actual treatment program. Now, one of the things that we have challenges in terms of women self-refer. We're still trying to work with clinicians to refer directly, and we have a clinician portal where clinicians can directly refer mums with her permission, obviously, and can sort of monitor what the mum is doing. We have risk alerts, obviously, and for mums who score rather high on the Edinburgh at registration, we have optional coaching, and there we partner with Panda, another wonderful organisation in Melbourne that has online services for mums. So you can see it takes a long time. I'm now getting that was MumMoodBooster. It took us from 1999. We started face-to-face treatments, then we diversified to prevention. Then we developed 10 years of digital treatments. And then we're incredibly lucky. We were awarded a Centre of Research Excellence, which is a competitive Australian funding. And Yafit, who you can see there, is our manager, the CRE manager. And I will show you what we aim to do in this next phase. So NHMRC is like your NIH or your NIMH, whichever country you're from, because I can't see everyone. I don't even know how international we are at the moment here. And so whilst the Parent Infant Research Institute leads it, and this is the website of STePPS, I'm a great believer in collaborations. I love collaborations. I believe that it's by pooling all our knowledge and efforts together that we can achieve the best outcomes. So this is STePPS, and I will show you in a moment the wonderful people that we've managed to bring to this effort. So our goal is to, how ambitious, revolutionize the digital delivery of perinatal service. We have a big aim. You have to have a vision. And we want to do that and bring along also early career researchers, upskill, build capacity, And we also want to consult the best minds at the moment that are out there to promote future leaders, but also to learn how to best do this. And we have 20 investigators from around the world. And you can see Annette is one of them there, who, I'll show you the next slide in a moment. But what was amazing is we thought, who can we approach who are some of the international research leaders in this field who can help us in this effort and clinical research? And we wrote to all these people, and miraculously, they all said yes. And so we have this wonderful team. And Rhonda, I saw you were here, thank you. So you can see we have Vivette, for those of you with Marseille. As some of you know, I was also president of the Marseille International for a while, and you can see there's Louise Howard as well. And so, you know, there's some wonderful people there, and I hope you recognize some of their names. But of course, in this day and age, it's not about just working as experts. We work very closely with lived experience. We have a lived experience advisory committee, and you saw Julie Bornenkopf there, who chairs it and runs Panda. And we really are also aware in this day and age about the importance to build trust with the community that we want to represent. Because of time, I'm not going to show. I've got a few videos I'm not going to show, but just to give you the sense.
When I think about those first few decades, my memories are of a deep and aching sadness. There was no rush of blood, no glow, no happiness, only tears and lots of tears.
So we have women who tell us their stories, and it's so powerful. It is just so powerful. And usually when they have recovered. Of course, we need to also acknowledge diversity. And in Australia, of course, we want to focus on Aboriginal and Torres Strait Islander people, but also we are very multicultural here. And so the challenge is how to make our work relevant to all our communities. So what's our vision? Our vision, I think, of this whole interest group is sustainable reductions in parental and infant morbidity. We want to empower parents. We want better, in our case, mental health interventions. And we want to try to innovate and personalize these digital interventions to meet individual needs. And so 3 of the goals of the CRE are here, and I'll give you an example in each of the 3 categories. We want to create better knowledge of things like what works best for whom, what sort of intervention is going to suit whom. You know, we're past one size fits all. We're very lucky. We know intervention works, but what works for whom, we still don't know that much. We want to increase the scope, not just for mothers, fathers, infants, families, maybe grandparents, and so on. We want to integrate with traditional services. So digital services shouldn't sit up there on their own. The vision is that they're an integrated part of care and influence policy and workforce capacity. So I'll start off with generating knowledge. An example, we're very fortunate as one of our investigators to have Professor Pim Cooper, who holds the most wonderful database that has rich data on a whole lot of mental health psychotherapies, including perinatal, and has done some wonderful meta-analyses and has the potential for addressing research questions of what works best for whom. And in a moment, I'll show you one of his students who's doing work with him and with us about this. And you can also see that I've got a very mischievous cat that I thought was asleep in the other room. So when you see a tail going across, you know what's happening. So we can learn from what we have by pooling international research together. And again, I'm not going to show you this wonderful talk by Pim, but it's always wonderful just to hear the guru talk a few sentences at least.
My name is Pim Kuipers. I'm a professor emeritus at Vrije Universiteit in Amsterdam, the Netherlands. and I'm chairing the meta-analytic work of the project. And I want to introduce myself a little, mostly my work. And what I want to do in this presentation.
Okay, so
My name is Ben Carter.
for you to find out about his work, you're going to have to go to his MetaSci website. And at the moment, we're very lucky. We have funded 4 early career researchers. Marketa Cherova is Pim Cooper's PhD student, and she's doing a wonderful meta-analysis, trying to predict using individual patient data meta-analysis to try to understand more about how we can target, how we can time, when should you give it, which stage of pregnancy, which stage of postnatal, when's the most impactful. Elka Katharis is focusing on fathers. We know it's so important, and traumatic birth, and the whole area of father's presence at birth. Sing Fen is looking at digital phenotyping, which is a really interesting developing area of technology, and particularly there's some very interesting digital phenotyping predicting postnatal depression. And then we are very fortunate, we have Naz here. You can wave, Naz, so that they know it's you, who's being supervised by Annette, and together going to be working on a conceptual framework for economic evaluation. This is very exciting work, and we really look forward to understanding more about how to evaluate and influence policymakers and what conceptual framework we might have for economic evaluation of digital perinatal mental health. So we're trying to generate knowledge. They were 2 examples. We're trying to increase the scope. So MumMoodBooster is perinatal depression for mothers, but we want to include diversity. We want to implement in the real world. We want to address mother-infant difficulties, and we want to address fathers, partners, singles, and trauma. So there's some of our targets. So we're really pleased because we just finished our trial for our Dad Booster program, which has been shown to be effective as well. So we now have what may be one of the first, again, for diagnosed depressive disorders in men, who also, we know that the incidence, in men is high as well. And, we can see, depending on what tool we're using, whether we're looking at major depression, I think, it probably hovers around 8%, but, it depends on so many measurement characteristics. We're always very vague about these things, but it's a fantastic program, and we never knew whether dads would also like doing online training, and we had a fantastic response. And so there we have a dad space, and the next frontier will be couples and culturally sensitive supports for dads. The next focus, as you may not be surprised as I've built up to it, is my early work was all about the parent-infant relationship. So full circle, I'm back there. I'm so pleased to be back there, because again, this is quite an interesting challenge. How do you influence a mother-infant, parent, father-infant relationship? It's quite hard. We have enough trouble delivering maternal and paternal depression programs. And we've developed a mother-infant program, HUGS, which is currently being replicated in France. Our RCT was successful, and it's being picked up in France. But now we try and develop an online intervention to see whether, again, with some coaching, we can help those mothers whose relationship has become dysfunctional as a result of depression. And this is what it looks like. And it's based on our successful HUGS program, which is a face-to-face one. And it really is based on developmental theory and other great work that's around the world. And just to give you again a bit of a taste, because today's just a taster, the sorts of things when we are addressing mother-infant interaction are understanding what do we think of as a mother-infant interaction that works. And Winnicott termed the phrase a good enough interaction. We're not trying to have these ideal mothers. What we want is a mother-infant interaction that understands the importance of turn taking, of reading infant cues, and the delight that happens when you do that. I'm going to show you this baby that obviously just so loves talking with her mum. And but understanding how to observe their baby's signals to know when a baby's had enough. And unfortunately, what we found in all our studies, starting with my PhD, is that, you know, when you have a mum who's very depressed and can barely interact, it's very hard to be very interactive with your baby. And so we reconnect mums and babies, those that have had difficulty. And it's wonderful to see that's happening.
Oh, that was loud.
It's very lovely work.
Wow, Zosa.
So we use play examples and things like that to help mothers reconnect.
Breaking.
Of course, we also use cognitive strategies, because very often they get in the way, like my baby doesn't like me, my baby's turning away, and sometimes after depression that does happen, so we tackle that. And so I've already talked that we're doing an economic evaluation with NAS, but I just thought I'd have your face there, Annette, showing that you're one of our major players in this, and we're really looking forward to the work you're currently doing. And again, this is a bit of a repeat, because this is the work you and NAS will be doing, is understanding potential costs and offsets. And there's a number of stages to your work, Annette. I think I did check I got your stages right, and I'm not misrepresenting you. And currently we're also gathering some data from dads to see about some of the economic impact on fathers in one of our trials. And the end product will be something we hope everyone around the world will benefit from, if there's a publishable paper that tries to address what are the important economic steps to take. So the final phase of our program, STePPS program, is the implementation phase, where we want to work hand in hand with services. And that is, where we're at in the last few years of our CRE. So Megan, we'll be talking to you a lot and other people, and Ron and so on. And we've been very lucky to have the support of government so far, of our ministers, for rolling it out. But now we really want to go one step further and all work together, the whole sector coming together to do this.
Hello, I'm Jed Carney. I'm the Assistant Minister for Health and Aged Care.
Yes, so you can see we've got that. So the last piece of my presentation is probably part that excites me, and I can also say because I think it's never too late to learn, right? And so what I want is to come along with a ride and learn from some of the best minds of how to navigate the new era that we're in. We want to develop digital technologies. We know that AI is here to stay, and that there's a lot happening, and we need to understand it, and we need to make the most of it. So we're all very familiar with AI already. I imagine if I could see all of you and said, how many of you use ChatGPT, there'd be a lot of hands going up already. Machine learning, language models, and AI is something that learns the more you use it, it learns, it gets a reward for positive responses. So this is supposed to be a funny play on a patient. I'm so tired of learning. Everyone expects me to constantly improve. But, that is what AI does. And so we have the potential to go further with how we deliver programs so they become more personal, using emerging technologies to give feedback in real time, for example. Like it's, you go and you do a session, but sometimes it's at the time when your baby's crying, you want that feedback right there and then. And, is there a role for virtual reality? I don't know. We're researchers. We want to know what works and what doesn't. But could VR help to deal with common stressors, such as feelings of by using virtual reality. And so there's so many emerging technologies, you know, and we're using, you know, we will be looking at data mining, large data sets, we hope, using predictive analytics. You know, there's sentiment analysis where you can, and using patient words for suicide prevention, trying to see, you know, some wonderful work that Black Dog is doing in Australia, if that, analysing language of you know, young people in therapy to see whether there are hints about the sorts of language that might predict suicidal ideation. So there's a universe of opportunity, and that's what we're very excited about. But also, have a look at this picture. What do you notice? There's a pram, there's a baby, and there's a mother and a father, but look, no one's holding the pram and they're on the edge of the precipice. So we need to be really careful about the risks as well. And we're very aware of that. So I keep wanting to get that pram, somebody holding that pram. And so we need to think about the risks of digital tools, of, you know, when, so for example, you know, for high-risk mums, we also use some human contact, some guided. They're the things that we want to understand more about. You know, there's a risk of these things emerging. There's apps all over the place. How many of them have been evaluated? You know, there's a real danger there as well. There's ethical, legal concerns, and so on and so on and so on. But I think that the way forward is to address these risks and be aware of them, mitigate potential harms as much as we can, make sure there's an evidence base to everything we do. In Australia, we now have to meet Australian requirements, and we're proud to say that we're accredited with the National Safety and Quality Digital Mental Health Standards. And there are courses such as this one that you can do to improve your ability to mitigate risk. So in conclusion, digital delivery of treatment will address an urgent global health problem we feel, and deal with more even distribution of services at a national level, consumer uptake, increasing access, and working with face-to-face treatment to impact on the burden of disease. So if you want to use this QR code, and if you put your phone there, or if you do in the recording, then it'll, if you want to collaborate with us, if you want to be on our list, do put it there and you'll get a message back from us about collaborating. I think I've made it clear I love collaborations, and we're trying to bring people with similar interests along and see what opportunities might exist. If you haven't got time to do this, or it doesn't work, do write to us. This isn't the end, it's the end of this talk. I'm just going to open up for some questions. It's just the beginning, though, for us at STePPS CRE.
That's amazing. Thanks so much for such an amazing presentation, and just, yeah, clapping my hands. But yeah, I think it's really appreciated. I think you raised so many issues around scaling and capacity building along all these kind of like various steps that you have taken in Australia, which is, yeah, really helpful. There's a bit of a question. There are some questions in the chat.
Yeah, so there's a comment there by RM. I imagine that's Rhonda Barrett. Trial results may point the importance of empowering women. That's a good through tailored program delivery. It is very important. And Rhonda, I look forward. We said in February we would get together, so we will. You'll get an email from me. That will be the start. It's a good statement. So there's no question there. It stands alone. Then the next question, I'm a psychiatrist coordinating perinatal mental health in Portugal. Hello. And Teresa, great. And considering attending, the Australasian conference, you're thinking of attending, Teresa.
There's a specific question, Jeannette, about, which I think has quite a lot of relevance.
Which one?
About the interface with healthcare. So I think, I mean, we just had an amazing conference in the Gambia about the Chime Project, which is like a singing intervention, it's a universal singing intervention, culturally embedded, almost like bypassing a lot of the kind of like need for integration. But I also know that, Jeannette, your MumBooster program has kind of like bypassed the healthcare system, which is very interesting considering the perinatal period is actually the period that women are in contact with healthcare services. So I think that kind of question of like how much does it need to be integrated, at what stage of the intervention, that's a really important question, it seems. So I don't know, Jeannette.
Yeah. I'll just say, Teresa, write to me, okay? And then we'll work something out. So I didn't present the work that we're doing of trying to integrate programs like MumMoodBooster to very early screening efforts that are now being promoted in many countries as a first step. So I can see the question is from Teresa, again, implementing an early intervention program, but and referrals only possible through general practitioners. So what we're also very interested in trying to do is to move towards self-referral, absolutely. And it really is a misconception that self-refer, I think we used to think that you couldn't screen women because it would result in this terrible problem. You'd have all these depressed women that the system couldn't cope with. Therefore, let's not even think about it, like let's shut our eyes and not screen. And that was really very powerful. It took us a long time to convince the healthcare system that we could screen. And then when we did screen, it did not result in that. I think it's an educational thing, really, that, the more you can identify, the more women can self-identify, the more professionals can identify, the more that we can facilitate pathways, like Megan's service is sort of triaging mums that are identified. The more that we can have those sorts of services, the more it has to be part of it. And, one of the things that we've done is because the people who screen, who are usually nurses in Australia, at the front line, aren't mental health professionals, and you get some nurses who are terrific. But so we've developed a very simple clinician support system, which electronically can pick up the screening results and help them develop a management plan just within the consultation. And we've just finished a trial of that too, and it's having good effect. So I think it's a good question. How do we integrate it all? It's terribly important. I think I'll stop there because first of all, there's a couple of other questions, and you also wanted to leave some time so another 3 minutes for questions. And I can see Megan's talking about the triage service, which I referred to without even seeing you put a comment there, Megan.
Well, it was really because Teresa was saying, how do we encourage the GPs to encourage them to self-refer, whereas we advocate for them. If they were ringing and they were unsure, we'd be saying, look, it's a really great opportunity, and sort of lead them and support them as a sort of advocate. And that seems to be having a fairly positive effect on behalf of the GPs. But I was just putting it there to support Teresa. Yeah,
but also our clinician portal allows GPs to monitor, for those GPs, Teresa, that are worried about not seeing, so they can actually receive all the alerts, because we monitor depression as people go through the program, and so they can see what's happening, and that can allay some anxiety. So, I know you asked me to finish on time, Annette, so we could have a broader discussion about the future of GOLT. If there's anyone who wants to ask a question verbally, a last question, and then we might stop there. Otherwise, we'll just stop.
Thanks, Jeannette. Yeah, I guess it's really about just discussing a bit. This presentation, I think, has been, as I said, like so amazing, kind of like really highlighting those issues around, how do you actually scale intervention? And STePPS CRE is obviously about exactly that, but in the digital space. which might be one way forward. But I think because, like as we are hoping to get a global group, there will be different perspectives from different countries, and there's no yes right or wrong answers, isn't it? Like it's really kind of like learning about what works in a kind of like country specific or even kind of like locally specific context. And I think that's what we are hearing, like from all the research projects that I'm involved in perinatal mental health. I think there is, it needs to be quite kind of like context specific. But I was wondering if people want to kind of like say a bit about kind of like where they are from, what they would like to get out of the group. Obviously, there's not much time now, but if you can put it in the chat, if you can raise your hand now, I think the chat has been already really helpful. But we can only kind of like set up the group in a way that's useful if we actually know what people want to talk about. We can have a bit more interaction about that, like maybe using like a poll but if maybe one or two people want to kind of come in and just say why they're here for and what they would like to get out of the group, that might be really great. I don't know, Teresa, if you had, if I can put you on the spot, because you are kind of like, is it okay? Do you want to say a bit about why you're here? You seem like you have a study that's going on right now. What would be helpful for you? Yeah.
Thank you so much. So talking from Portugal, a bit far away. So I'm at the moment managing a program that is including more than 300 doctors, primary healthcare doctors. And the idea was to create a system which is inside the primary healthcare doctors. So the program that they use daily for their clinical registrations. So we have an interoperability system that inside the system, they can refer women to be screened for perinatal mental health during pregnancy and postpartum. And then after the women answer the screening, what happens is that the doctors receive alerts if they have some risk to be developing, especially perinatal mental health depression. The thing is that, and this was based in a huge work that we have been doing for the last 3 years. So we're now extending from our general hospital where I'm coordinating a program to primary healthcare, so we can have all the women screened. The problem is that GPs are not doing this referral, although it's very simple. It's like doing a click while they are doing their appointment, their regular appointment. And women have a lot of appointments during pregnancy. They're not doing this. I think this is, well, they're overwhelmed with work. And I think there is a lot of resistance of changing anything at all, even if it's just a click, which is very painful, honestly, because it was a huge work to put all this together, to be able to create this interoperability inside the program. So this is very, very simple. And now they're not doing this. And at the moment, I'm trying to argue and ask for the possibility of self-referral, but they are not doing the screening, but at the same time, they are resisting to this because they say that there might be some risk if women are identified with perinatal mental health problem and they were not aware or in contact with this woman. So I know it's a bit silly, but I'm really having a lot of problems of like changing because they don't do anything, but they are not letting me doing. So any thoughts of wisdom that might help me to get
in the next 2 minutes? Yeah, no, thanks so much, Teresa, for sharing. I think that's
Teresa,
if this doesn't work, we will not probably have any extra funding to replicate for all the country. This is the problem. So because they're not showing, they're not doing this, we are at the risk that the government states that, well, this is not working, so it's not worth investing.
Yeah, thanks so much. So I just want to say, because we only have 2 minutes left already together, but that's really helpful. I think that's exactly the kind of issues that we will be discussing as part of this group. I don't know if Naz had a quick advice on if like a specific practice issues come up, because that is obviously an issue that I think other people will have experience, and people like Jeannette will offer advice, but there might be others. So I wonder if there is something around, like, that could be a discussion point we could be taking on. I don't know, Naz, if you had an advice on offering like a group on this, or we could have a presentation on it and discuss it a bit more in detail at another meeting. Naz, do you want to give some advice on how the group can help?
Yeah, I think just to
No,
say,
sorry,
Teresa,
yeah.
it's a very common problem. Like, we have the same problem even with Yafit is recruiting, even with midwives referring to breast, like getting that is still a barrier, that referral. So I think like you say, Annette, like, we've tried many things, and we're still trying, and we will keep trying. So bringing together people who can brainstorm this is a great idea.
Naz, do you want to?
Yeah, I just quickly want to say that the whole purpose of these types of webinars is so that people from all over the world can share their experiences. And if someone does have more knowledge on it, they can share it in this webinar as well, and try and combat the struggles that sometimes we all face in different parts of the world, but they're the same struggles. And then Adelina?
Yeah, just to add one thing you can do. Of course, we have a list of members of the group who are people who have created a profile and who have said they're happy to be contacted about things to do with this group. So we have the potential, for example, to email all the members with a question, but you have to do it through us, and then make sure that they're all happy to respond to you. So you can always contact us and say, could you send this email, or could you share this among the group? The other thing some groups have done is to create a Microsoft Forms small survey to identify people who are interested in certain things, and so on. So we can also make that available to you.
That sounds really nice. I think that the latter idea is in particular, I think, really helpful. So we can kind of get an understanding if over time, obviously this is the first meeting, we are getting kind of like common interest areas and create kind of like groups around those, because obviously they're so complex questions we can't address within like a few minutes. But thanks so much, everyone. Thanks, very much, Jeannette, for coming and for supporting this group and connecting the STePPS CRE. That's really amazing. And I think we're just bringing it to a close now, just to keep on time. We are running 1 minute over. I apologize. But yeah, thanks to Adelina and Naz and everyone who attended. And please do get in touch. This is meant to be an active group. It will become more active over time. So if you have ideas how we can link it with your thoughts, your projects, your resources, please get in touch. Yeah.